by my previous speaker, there are like several phases of the fungal infections in the patients. I will like to take you through several cases which show the various phases of the fungal infections in the critical care patient, ICU patients. So this is the first case. He is a 44-year-old male known case of COPD, a chronic alcoholic, who presented with respiratory distress. He had fever, leukocytosis, and the CT showed bilateral patchy, alveolar patchy infiltrates. And on the 4th day of mechanical ventilation, CBC day 5, Follies day 5, he had these manifestations. He initially had tested positive for the influenza A virus and was on oseltamivir and worsening conditions, so he was started on empirically meropenem and teicoplanin. The ARDS further worsened and developed septic shock and also required dialysis. So at this stage, what would be the diagnosis? Probably. Anyone? As I said that it is a fungal infection, all the various spectrum of it. So it is a case of aspergillosis, invasive aspergillosis. As we know, the aspergillosis has got a wide spectrum of manifestations. When the immune system is intact, it would present as allergic bronchopulmonary aspergillosis or a hypersensitivity syndrome. When there is some structural disease or inflammation, it may manifest as aspergilloma, chronic pulmonary aspergillosis, and semi-invasive forms. But when the immune system is very much suppressed, it may present as invasive pulmonary aspergillosis, invasive bronchopulmonary aspergillosis, and even extrapulmonary manifestations like involving the CNS. So how do we go about a diagnosis of these patients? We should have a high index of suspicion basing on the risk factors of the patients. In these patients, in this individual case, he had influenza. So the post-influenza aspergillosis is a well-known entity. The immune status of the host can give us a clue if he is likely to develop these fungal infections. The signs and symptoms are not very specific, so there is a lot of overlap between the other pathogens as well. So keeping a high index of suspicion is essential. Then we can go along with the radiological investigations like going for a chest X-ray, HRCT or CCT chest. And there are several biomarkers which can help us. The galactomannan, beta-D-glucan, they can help us by making a fungal diagnosis. These days the PCR are also available to us, and the lateral flow assays for several fungi are also there, like the cryptococcosis, Histoplasmosis and all. We need the biological samples for making a diagnosis by microscopy and culture. The bowel fluid can help, and even the lung biopsies are helpful. This slide shows the various spectrum of changes that occur in the patients with the aspergillosis. So when initially it involves only the bronchial part of it, it may manifest as bronchiectasis or tree and bud appearance or ground glass opacities. But when it proceeds into the angio-invasive phase, it may further present in the CT as a ground nodule with halo, the consolidation, or even dissemination. The galactomannan levels, when the disease is invasive, the levels are expected to be very high. There are several criteria for whether it is a proven invasive pulmonary aspergillosis, a probable or a possible one. The EORTC MSG criteria has been given. It includes for the proven IPA, we need to have a microscopic or a histological diagnosis where the aspergillus or hyphae needs to be manifested demonstrated maybe in a sterile sample or in a tissue biopsy. And even the growth in the culture is essential. For telling it as a probable or a possible IPA, there needs to be more than one host factor along with the imaging factor and mycological evidence. Possible IPA, any of one of the criteria of possible, when not fulfilled, it comes into the possible. So these are the various risk factors that are there for telling whether the patient is immunosuppressed or not. The risk factors include for telling it as a proven possible IPA include neutropenia, transplant recipients, usage of corticosteroids. We always keep saying that high dose corticosteroids, high dose we need to know what is actually it is. It is when the patient is administered more than 0.3 milligram per kg per day for 3 weeks, it is the high dose corticosteroids. And there are other conditions like the T cell usage of T cell immunosuppressants and severe inherited deficiency. These all conditions amount to the immunosuppression. And the clinical factors which include which are included in the EORTC criteria include on the CT scan, the well-described, well-circumscribed lesions with or without a halo, air crescent sign, presence of a cavity, and wedge-shaped lesions. The mycological criteria includes this following: the presence of positive direct hyphae on the specimen, or a positive culture, or these two are essential for proven IPA. The other markers include the BAL galactomannan, BAL fluid PCR, or the serum PCR. The newer EORTC guidelines that have come in 2022, they have included the PCRs in along with the cultures in the criteria. And on the right hand side, you can see the various appearances on the direct mount of the cultures. The various aspergillus have got various morphological appearance, and we can make a diagnosis of which species it is, as certain species have different antifungal susceptibility. So knowing the species of the aspergillus is also very important. Like this aspergillus teres, it is inherently resistant to amphotericin B. So if it is detected, we should not be administering the patient amphotericin. These are the guidelines for the management. As we know, the azoles, the voriconazole is the first line of therapy. Isavuconazole has also been included as a grade A1 evidence, like it is non-inferior to voriconazole. And wherever we have a like suspicion of mixed infection with the aspergillus and mucormycosis, we should be going ahead with isavuconazole or posaconazole. In the treatment armamentarium, we have with us the azoles, being the first line of treatment, and amphotericin B if azoles are contraindicated. And as I said, like if it is aspergillus teres, it should not be given as it is intrinsically resistant to. There are like no head-to-head comparisons between liposomal amphotericin B and voriconazole. Echinocandins may be rarely used if the other things are contraindicated, or as a salvage therapy. And the crude mortality rate of these invasive pulmonary aspergillosis is pretty high, ranging to about 65 to 70%. This slide shows the various appearances of, the slide is not pretty clear, but it shows the various appearances of the various infections in the lungs due to the various etiology in the various phases of hematological malignancy, like in the pre-treatment phase, the treatment phase, and the consolidation phase. The pathogens are different and the appearance on the CT scan are also different. This slide also summarizes the various infections that may manifest on the in the patient, like we can make to certain extent guess diagnosis based on the appearance on the CT scan. Like in the aspergillus there and mucormycosis, the nodular lesions are present, and cavitation is also present in histoplasmosis. The consolidation may be present in aspergillosis as well. And ground glass opacities may be seen in the pneumocystis. So coming to the second case, he is a 32-year-old male who presented with cough, chest pain for 1 month. He did not have fever. Hemoptysis was present for past 2 days. He was on chemotherapy for CML on triple immunosuppressants. The other biochemical markers were normal. He had a raised CRP. The sputum culture and gene expert were negative, and he had worsening symptoms despite the administration of antibiotics which he received outside for CAP. So in this case, what would be your diagnosis? Anyone? So this was a case of mucormycosis. The CT scan is shown here, which showed this one. You can see there is a bird nest appearance or the reverse halo sign, and bronchus EBUS was done, and we demonstrated the hyphae. Broad acceptate hyphae with right angle branching, and it was diagnosed to be a case of pulmonary mucormycosis in an immunocompromised patient. So we should be having there are certain risk factors which predispose the patient to pulmonary the other invasive forms of mucormycosis. And this slide shows according to the condition, the sites of involvement, the primary sites of involvement of mucormycosis may be different. Like in the patients with diabetes mellitus who have more so in the diabetic ketoacidosis, the most common site of involvement is the rhinocerebral mucormycosis and the sinoorbital. But in the hematopoietic stem cell transplant and the malignancy patients, it is the pulmonary mucormycosis which is more commoner. In the solid organ transplant and IV drug abusers, it is different. In the sinus and the cutaneous are more common in the solid organ transplants. IV drug abusers, it is the cerebral, and in the malnutrition, it is the GI mucormycosis, which is more common. For making a diagnosis of the mucormycosis, the symptoms are not very specific, like they overlap with the other infections as well, like hemoptysis, chest pain with or without fever. So we cannot make a differentiation between the various organisms based only on the symptoms, and it is also very essential to differentiate it from the invasive pulmonary aspergillosis, as the management is totally different for the two. And a negative galactomannan and the beta-D glucan and aspergillus specific PCR, they can help us in making a diagnosis, because in case of this mucormycosis, the galactomannan and the beta-D glucan which are there in the cell wall are absent. So for making a diagnosis, we should be like having a suspicion in the mind, high risk patients with a clinical presentation and culture. So definitive diagnosis can be made only if a tissue biopsy or a pleural fluid aspirate or a sterile sample shows the organism either on histopathology or a growth is obtained. This slide shows the various ways of progression. Like initially, you can see the reverse halo sign or the bird net sign, and on the biopsy, the various you can see the black necrotic ulcer. We can make some differentiate to some extent based on the CT chest finding between mucormycosis and aspergillosis. In the aspergillosis, it is the halo sign which is present, but it is not very specific to the aspergillosis. But in the mucormycosis, it is the reverse halo sign, which is the ground glass opacity surrounded by a ring of consolidation. The micronodules are present in the case of mucormycosis, and in the case of aspergillosis, it is the macronodules that are larger than 1 cm in size. The air crescent sign is seen in the aspergillosis, whereas that is not seen in mucormycosis, and a large ground glass halo is seen in the mucormycosis. Based on the microscopy on the histopathological specimens, we can differentiate between the two. The slide on the left hand side shows the mucormycosis, which are aseptate or pauciseptate with wide angle 90-degree branching, and broad, the hyphae are very broad. Whereas in case of aspergillosis, it is the septate acute angle branching, and they are thinner. So if we have a suspicion of the mucormycosis in mind, we should be instructing the lab because they need to process the sample differently. They should not grind the sample, otherwise the fungal elements of mucormycosis are very friable. So we might not recover the mucor. So if we have a suspicion of mucor, we should be telling the lab people to process the sample differently. Coming to the management, it is a three-pronged approach, like the antifungal agents along with the surgery and control of the risk factors is very essential. Going for the surgery, antifungals, and control of the risk factors like decreasing the immunosuppressants, managing the diabetes, ketoacidosis and all is very essential. And the antifungals that we have in armamentarium include the liposomal amphotericin B, which is the drug of choice, and followed by in the continuation phase we give for posaconazole or isobuconazole. Despite that, the rate of mortality is pretty high, ranging to the rate of 80 to 85%, and if disseminated, the mortality is very high, up to 95%. These are the ECMM ISHAM guidelines, which state that the three-pronged approach, like control of the risk factors, diabetes control, reducing of the steroids and immunosuppressants, and extensive surgical debridement along with the medical therapy. The liposomal amphotericin B is the first line. The isobuconazole has also been included if the patient cannot tolerate the amphotericin B for some regions. This is the new kid on the block, the isobuconazole, which has been available to us maybe for last 2 years. It has got a very good susceptibility profile and good bioavailability and less interaction with the other immunosuppressant agents, good tissue penetration as well. But it has got a higher cost, which is limiting, and it has got no role in the UTI. Coming to the newer developments, the patients who are on azole prophylaxis or posaconazole prophylaxis, if they develop the breakthrough mucormycosis, the mortality rate is very high. This has been studied in a few studies, in which they showed that the patients who developed breakthrough mucormycosis and mucorale active antifungals had a higher 42-day mortality from either symptom onset or treatment initiation. Coming to the third case, he was a 56-year-old male, an active smoker who presented for general examination. He was asymptomatic. He got a CT test done for ruling out if he had any malignancy, but the CT showed several nodules. So he underwent a CT guided biopsy, and to our surprise, the fungal stains showed these structures. The cryptococcal antigen in the serum was positive. So it was a case of pulmonary cryptococcosis. As we know, there are two species of the cryptococcus, the Cryptococcus neoformans and the Cryptococcus getae. The Cryptococcus getae is the one which is more associated with pulmonary findings, whereas the Cryptococcus neoformans is more associated with the CNS cryptococcosis. It is like the Cryptococcus getae is found in the soil and in the eucalyptus trees, and there have been several studies from the North India where they have shown that the Cryptococcus getae was the one which was isolated from the pulmonary cryptococcosis in many of the cases. Like this is the Indian data which showed that among 199 cases there were about 10% of the cases were Cryptococcus getae, and we need to know because the amphotericin B resistance is much more with the cases of Cryptococcus getae. Yeah. And more so they occur, this Cryptococcus getae is known to more occur in the immunocompetent patients, and it also requires a prolonged induction therapy since it tends to form cryptococcomas, and also it affects the immunocompetent patients. And the antifungal resistance is more in the Cryptococcus neoformans. And in these cases of cryptococcosis, we should not be tapering down the immunosuppression very abruptly, as this can result in the life-threatening IRIS, the immune reactivation syndrome. These are the various risk factors which predispose the patient to pulmonary cryptococcosis. The host factors include the HIV, solid or stem cell transplant patients, hematological malignancy patients, patients on immunosuppressive therapy, end-stage liver disease. And the clinical features usually it is like the CNS cryptococcosis with a meningeal inflammation and radiological signs consistent with cryptococcal disease, and mycological evidence with either obtaining it on the microscopy or culture or in the cryptococcal antigen is essential. There is a review article which you can go through on pulmonary cryptococcosis itself, and in that it was shown that the cryptococcosis was about asymptomatic in 34% of the cases. These are the various EORTC criteria for making a diagnosis. So the pulmonary cryptococcosis, it may present on the CT as a segmental consolidation, a cavitation, or a bilateral bronchopneumonia, mass-like appearances. There are several presentations which it can manifest. And on the tube you can see like the cultures, and the below one is the antigen test which we undertake, and the antigen test is also good sensitivity and specificity. In the immunocompetent patients, it is usually presents as a single or multiple nodules with bilateral discrete lung involvement and pleural effusion, whereas in immunocompromised patients, it is diffuse lung infiltrates, usually with dissemination, and cavitations are more common in the immunocompromised patients. The treatment modalities are different. Like if it is the patient is asymptomatic and has only the CRAG antigen positive, then we can go ahead with fluconazole 400 milligram for daily for about 6 to 12 months, and discontinue when the patient has a CD4 count of more than 200. And if it is the CNS involvement is there, then we need to go for the therapy with liposomal amphotericin B initially, followed by a consolidation and continuation phase. The cryptococcal antigen has got a very good sensitivity and specificity. This slide summarizes the various appearances of the various fungi on the microscopy, and the risk factors and all are different. Coming to the fourth case, she is a 34-year-old woman, a known case of RBD, who was on ART for last 5 years but had discontinued for the last 6 months. The CD4 count had fallen to about 10, and she presented with 3 weeks of dry cough, weight loss and dyspnea, and had been receiving antibiotics suspecting it is a community acquired pneumonia outside. There were a worsening of the respiratory symptoms and a very low SpO2 of 90% on face mask of 12 liter. So what would be your diagnosis in this case? Yes, it was a case of PCP pneumonia. So the risk factors include HIV patients, RBD patients with CD4 count of lower than 200, and the other non-HIV cases where it can occur include the hematological malignancies, the solid tumors, transplant patients, end-stage liver disease, and the patients on like immunosuppressions like cyclophosphamide and TNF-alpha inhibitors. The prednisolone itself is an immunosuppression, but it is also involved in the management of these cases. The WHO case definition for the HIV people with surveillance includes presence of dyspnea on exertion or with or without non-productive cough of recent onset within the past 3 months, and the chest X-rays showing bilateral diffuse infiltrates and no evidence of bacterial pneumonia and bilateral crepitations. The PCP pneumonia has been graded according to the alveolar arterial gradient as a mild, moderate to severe. And there are certain differences between the HIV patients and the non-HIV patients having the PCP disease. Like the LDH is not very specific. It may be it is higher in the more so in the HIV negative patients, and the HIV negative patients have a higher mortality when they have the PCP infection as compared to the HIV patients. And the HIV negative patients have very rapid downhill course. We need to address the potential reasons for the deterioration in these patients, which can be additional infections, resistance, treatment failure, or suboptimal therapy. Mutation in the FAST gene can contribute to the treatment failure in these patients. These patients have a elevated LDH and diffuse perihilar infiltrates, normal chest X-ray. And these are the various findings which you can have on the CT scan of these patients. They can be having patchy ground glass opacities, smaller cysts may be present, or even interlobular septal thickening can be manifested in these patients. We need to have a microbiological diagnosis on the PCP. We need to go for the GMS staining, and we can see the PCP bodies, and also in these patients the 1,3-beta-D glucan is very high. So the 1,3-beta-D glucan can act as a surrogate marker for making a diagnosis for the PCP if we have a high index of suspicion. And the cutoff levels include more than 200 milligrams picograms per ml. The specificity is about 100%. The management of these patients is cotrimoxazole for about 21 days with tapering doses of steroids and along with clindamycin. The role of steroids is very essential, and the dosage are as follows, like 40 milligram for twice daily for 5 days, then 40 milligram once daily for 5 days, and then 20 milligram once daily for 11 days. So we need to remember that a standard course of treatment for these include 21 days of management with these drugs, steroids and the cotrimox, and followed by a prophylaxis, which is we need to start the ART within 2 weeks. And if not treated on time, the illness is a very downhill course, and fatality can be very soon. This is a case which we had seen at AIMS. The patient presented with a skin lesion and the pulmonary and had fevers and SOB, and he had a history of travel to the South America. So the bronchoscopy was done, and the bowel sample was put to culture, and we grew these fungi. So it was a case of blastomycosis, which do not come across it usually, and these are very rare. So patients who have a history of travel to the Americas, we can have a high level of suspicion if the disease is ruled out. And the management of these patients includes induction phase liposomal amphotericin B followed by a maintenance of itraconazole. This is another case. A 50-year-old male who was resident of Uttar Pradesh along the belt of Ganges, and he had presented with a history of scanty whitish expectoration and intermittent low-grade fevers and skin lesions, as you can see in the picture. He had a weight loss also for 3 months. The chest X-ray was normal. The CT showed calcified mediastinal nodes and hepatosplenomegaly. He was HIV negative, and the skin biopsy of the lesions that were there on the face, it showed a dense dermal infiltrate and multiple histiocytes, and intracellular organisms were seen of about 2 to 5 micron and surrounded by a halo. So what would be your diagnosis in this case? It was a case of histoplasmosis. As we know, along the belt of Ganges, the histoplasmosis is pretty common, in the West Bengal and the other northeastern states. Even in our center, we have diagnosed about 4 cases of histoplasmosis over the last 3 years. The spectrum of these diseases varied. It can present as acute pulmonary syndrome or a chronic cavitary pulmonary disease and ranging up to progressive disseminated histoplasmosis as well. The management is initially amphotericin B followed, and it may be even self-limiting. And if it is like a chronic cavitary pulmonary disease, we need to go for itraconazole. Progressive disease needs to be definitely given amphotericin B, followed by itraconazole, and the duration of treatment is about 12 months. This is the case of a 31-year-old who presented from Manipur with, and he was IV drug abuser with fatigue and loss of appetite and cough. And he had these skin nodules on his forehead, and also had loss of appetite and cough. So the investigations were undertaken. The CT showed subcentimetric mediastinal nodes and a hepatosplenomegaly. The CD4 count was less than 450, and the bone marrow showed scattered histiocytes with round to oval 2 to 4 micron sized bodies. There was no granuloma necrosis. So what would be the diagnosis in this case? Anyone? Taking the history into account and the status. So it was a case of Talaromycosis, earlier known as penicillium. It is more common in the northeastern states like the Manipur and the other neighboring states. And it also is a differential of histoplasmosis and cryptococcosis, as they have similar skin lesions and lung lesions. These cases have a very poor prognosis, and the mortality rates are higher, and the management is similar to histoplasmosis. Initial 10 to 14 days of amphotericin B, liposomal amphotericin B, followed by consolidation and a maintenance phase of about 12 months.